Well, hello and welcome to the first motor neurone disease webinar of 2024. My name is Baiga Hastus and I'm the chair for this afternoon's session. Before we begin, I would like to thank Zambon UK for sponsoring this afternoon's learning. First up will be Bernie Kaur, an MND clinical nurse specialist discussing symptom management in MND with an emphasis on the MDT. So, without any further delay, I'll hand you over to Bernie to start this afternoon's session. Bernie, over to you.
Hi, I'd like to thank you all very much for welcoming me to come to speak today. I work with Professor Hardyman in Beaumont Hospital in Dublin, and I joined Orla in 1996, quite a long time ago, and our service has developed and expanded over those years, and I'm part of a very large multidisciplinary team and also a research team. So I'll go through my slides. Next slide, please. Sorry about this. So MND is a relentlessly progressive neurological disorder, culminating in complete dependence on others for all activities of daily living. The clinical management of MND is palliative from the time of diagnosis. It's focused on symptom control and the adjustment to the progressive loss of neurological function with the certainty of early death. I suppose what varies from person to person is that the illness is a very individualized illness, and it'll vary from one person to another. So we could have two people diagnosed at Christmas, and by Easter time, they will both have proceeded at quite a different trajectory from their illness. It's the commonest neurodegenerative midlife, unknown etiology. We have an incidence of 2.6 per 100,000 and a prevalence of 1/16. We now know and have a much better understanding that there's an overlap with frontal temporal dementia. This was missed for quite a long time. It's a disease of adulthood, some exceptions. We have a peak of 50 to 70 years of age. In Ireland, we have had two 15-year-olds, both who presented with limb onset motor neuron disease. Both had a fairly rapidly progressive motor neuron disease and died within a year of their first symptoms. There's a lifetime risk of 1 in 3 to 400 for all of us. Motor neuron disease is known as the disease of 1,000 days because 70% of the patients who get motor neuron disease will die within the first 3 years. We have 30% then who survive beyond that. And for whatever reason, their illness, the trajectory is quite different. So we have some outliers that have lived with us for maybe 10 years, 15 years. For some people, they can have a very aggressive type, then the illness stops to progress, but they are quite disabled, but they continue to survive, but the illness hasn't progressed. In Ireland, up to 20% of people with MND have another family member with an MND or full temporal dementia. And 50% of these kindreds in Ireland carry the C9orf72 gene. So what we've started to do in our clinic, as I said, I'm part of a very big multidisciplinary clinic. We are now doing genetic testing on everybody that comes to us with their consent. We don't, interestingly, have the SOD1 gene in Ireland. So we have the C9orf. We've had a trial looking at the C9orf. So we are contemplating whether we now start to have to do pre-symptomatic testing based on the fact that we have some trials. We also have a FUS trial coming on, and we have a very interesting family in that we have a young girl, her first cousin who's a boy, and her other first cousin who's a girl, and both their dads died with motor neuron disease, and they all carry the FUS gene. So that's very interesting. So we're beginning to see more of the genetic stuff and having a better understanding of it. Next slide, please. The other related conditions that we see in MND families are, we see the frontal temporal dementia, we see autism, obsessive compulsive disorders, bipolar disorders, we see an overuse of alcohol, impulse discontrol, and we see psychosis. Next slide, please. As I said, I'm part of a very big multidisciplinary team, and we have an advanced model of care for motor neuron disease. We provide a national service from Beaumont Hospital with specialists providing in-house and outreach service. We have a multidisciplinary team providing face-to-face, video link and home visits. From a nursing perspective, we have a new AMP joining us, so we have 2 AMPs and 4 clinical nurse specialists. We have one clinical nurse specialist based in the hospital, and the rest of us are in and out, but we provide a national outreach service. So we travel the whole country, meeting up with other healthcare professionals, community team meetings. We also manage the respiratory management of MND patients from the point of view that we do pulse oximetry at home. We set up NIV at home, and we will monitor the management of our NIV intervention. We integrate with the primary care teams and the palliative care teams, and we link with central immediate clinics who are providing equipment. We have a very close contact with the Irish Motor Neuron Disease Association. I think our association may provide more equipment and supports than any other association around the world. So we can visit people and basically come out with a shopping list and request beds, wheelchairs. They provide grants. We have counselling support. So it certainly makes it very easy for us from a management point of view to have the support of the association. And when I started working in 1996, I was the only nurse in the country, and I provide a consultancy service for the association. I was then chairperson for the association for a number of years, but with some funding and huge donations from the Irish population, the association now has actually 6 nurses working for them, providing a national service. They come to our clinic. So we have a very close and an unusual relationship, but actually we work very well together, and that was to benefit patients, families, and other healthcare professionals around the country. And I suppose from the point of view of the clinic as well, it means that patients have access to all our clinical trials. Next slide, please, Emily. So our team consists of, and as of 2023, we have the health service executive. That's who's in charge of our health service in Ireland. But Orla, Professor Hardyman, has actually managed to ring fence funding for all of us. So we're not depending on funding from the hospital. This has been protected by the HSE. So we have 2 consultants. We have Orla, and then we have Dr. O'Brien, who's a consultant in the hospital. And then we have 2 advanced nurse practitioners, 4 clinical nurse specialists. We have 2 specialists, the registrars, who are fully based for our team all the time. We have physiotherapy, occupational therapy, speech therapist, dietitian. We have senior social worker, senior psychologist. We also have an assistant psychologist joining us. We have respiratory physiologists, because when people come to our clinic, everybody has their respiratory measurements assessed, and we have a baseline. We do an ECAS, which is the Edinburgh Cognitive Assessment Scale. We do that at every visit. And we also do the behaviour, the Bowman Behavioural Inventory. So that gives us a good understanding of where people are from a psychological point of view. And then we can refer on to our senior psychologists if we need a full battery of tests. We haven't quite managed, we've advertised, but nobody has responded to our genetic counsellor, but we do plan to have a genetic counsellor on our team, given the impact of the genetic type of motor neuron disease and the importance of perhaps identifying pre-symptomatic families, because if there's going to be treatments, we might need to start thinking down that way. We have data managers, and we have clinical administrative support. So we have a huge team, so we're very lucky to have this level of support. Next slide, please. MND is a complex disorder. Disease-modifying therapies are limited. We know that early intervention can alleviate the symptoms, and that multidisciplinary and integrated care can enhance quality of life and may improve survival. Next slide, please. In Ireland, 1 person dies from motor neuron disease every 3 days. We also have 1 person being diagnosed, so our figures are fairly constant. But that has a huge impact on healthcare professionals and on families. Next slide, please. So the symptoms will depend on where it starts. And motor neuron disease is a combination of upper motor neuron and lower motor neuron with progression. The upper motor neurons in the brain, lower motor neurons in the spinal cord, and it's damage to both that cause the problem. So it depends where it starts. So we see slurred speech, swallowing difficulties, breathing difficulties, clumsy hand, limp, tripping, falling, cramping. These are the symptoms that we can see. Next slide, Emily, please. The upper motor neuron signs cause slurred speech, emotional ability, the spasticity, the paresis, the decreased fine movements, brisk reflexes, and upgoing planters. And these are signs that are found on a clinical presentation with the person. Next slide, please. The lower motor neuron signs are wasting, weakness, and fasciculations. And often you'll see a split hand with MND patients. Next slide, please. There's no definitive diagnostic test, so it's often a case of excluding other causes of the symptoms. We'll do blood and CSF, they're usually normal. Imaging is done, which is usually normal. Electric EMGs and nerve conduction studies are getting more sophisticated and are helping in the diagnosis. I think this can be a difficult time for the person because they're having all the investigations done and things are coming back and they're normal and they're thinking, oh, I don't have a brain tumor, I don't have cancer, I don't have this, but actually there's no other reason to explain the clinical presentation that they have and the progression of the illness. So, you know, as the tests are being done, we're thinking, oh God, we're getting worried. So there's problems and the person is thinking, well, maybe it's not so bad. Next slide, please. So MND is a series of losses. It's a loss of control, independence, the patient's security, their identity, their role, their status, self-esteem, the body image, their sense of attractiveness, the opportunity for privacy and intimacy, for their friends, their work colleagues, extended family members, and for their future plans and ambitions. And I guess the thing that's important with motor neuron disease is that today is as good as it gets. They don't ever regain any ground that's been lost. So today is as good as it is. And then what just varies from person to person is how fast and the disease is going to progress and how it's going to impact on them. Next slide, please. So for many, what began as a minor symptom has turned into a disabling and fatal illness for which there is no cure. Now, lots of illnesses, there's no cure, but they're managed. Like if you have cancer, you have the possibility of having chemotherapy, radiotherapy, you might go into remission. But with motor neuron disease, you don't regain any ground that you've lost. Next slide, please. So the impact of MND is most definitely a unique and individualized experience. It's influenced by how the patient and the carer perceive the changes caused by the illness, their previous coping mechanisms, and the presence of support structures and the strength of their relationship prior to the diagnosis. We had a young guy recently who presented with a weakness in a hand and an arm, and we're saying, well, you know, this is very mild. It's, you know, it's not progressing very fast, but he was a rally driver, so immediately it's impacting on his life. We're saying it's not too bad, but his life is changing, and the life that he knows it has changed immediately. It also puts a huge amount of pressure on relationships that, you know, I don't know whether it's because for many years we didn't have divorce in Ireland, but we have people who live together but actually don't share life together. And then that can put a huge relationship on their, you know, a huge strain on their relationship if one person has to care for another. So these are the challenges that we face with motor neuron disease. Next slide, please. So it challenges the person to unlearn the mastery of the body, to unlearn personal control and independence, and to return to a state of complete dependence, which is a terrifying thought. Next slide, please. The clinical features of MND that we now know that relate to prognosis. We know that the cognitive impairment has an impact. Bulbar carries a poor prognosis and spinal onset. Bulbar being where patients present with a speech and swallow problems. Spinal if they present with a weakness in an arm and a leg. The age of onset. As I said, the rate of the disease progression. So if we have two people and we see people fairly regularly depending on their symptoms, we might see very little change in one person, and in another person every 2 weeks or every 3 weeks that we see them, there could be a significant change. That usually carries a bad prognostic indicator if the disease is moving very fast. We know that some patients present with a respiratory onset motor neuron disease. This always carried a poor prognosis, better managed now with NIV and with cough assist. And we know from research as well that nutritional status, some people will lose weight based on swallow and the reduced caloric intake, but there are some patients who will lose weight because of the basic metabolic rate is raised, and we see that more so in patients with respiratory onset MND. Next slide, please. So MND is going to be classified according to normal with patients with ALS with cognitive impairment, executive impairment, non-executive impairment, and ALS with frontal temporal dementia. And it's very important that we have an understanding of how the illness is impacting on these patients and for their families. The burden of care is very challenging for some of these patients and their families. Next slide, please. The clinical features that we see that relate to the frontal temporal dementia involvement is there's a violation of interpersonal space, overeating, food fads. People report to changing their preference and eating lots of sweet food, blunted emotions, swearing, increased interest in sex, and inappropriate behaviour. This is often very difficult for families if there's been a change in the behaviour of their mum or their dad or their husband. Their lack of judgment, impulse buying, the disinterest and withdrawal, the lack of empathy, the apathy that they have. We hear stories of hoarding, repetitive behaviour, changes in personal hygiene. And we've had one or two patients that we've looked after who had criminal behaviour and have ended up in a mental hospital after he murdered somebody and was found not to be, had no capacity. And we have another patient presently at the moment who is in one of our security prisons in Ireland. And we've been very fortunate that we've been invited into the prison to provide our service so that whatever he requires and wherever his needs are, regardless of his conviction and his sentence, but we've been invited in to provide service and provide care for him going forward. So that's been very useful. Next slide, please. The cognitive and behavioural deficits are now recognised as important factors in the diagnosis. They can be subtle, moderate, severe, and we have a feeling that they are evolving. Because we follow all our patients at home, and we get to meet them at the diagnosis in the clinic, and we follow them and manage their care until they die. Some patients that initially may not have presented with any cognitive or behavioural issues. As the illness progresses, there are some people that actually do develop these problems. So we're talking about at the moment about maybe doing a study just to follow and to see if we can track the changes that there are in the behaviour and the cognition from the beginning of the illness. Because I think initially we thought maybe it was, if you had these changes, you presented at the beginning, but perhaps as we're seeing people more and more as the illness progresses, it is evolving. We know it has an increase in survival or an impact on survival. It has impact on decisions regarding finance and end-of-life decisions. It has an impact on the compliance, whether patients are going to comply with using NIPPs or having rigs or augmentative and assistive communication devices. It has impact for their safety awareness, falls, avoidance, choking episodes, and there's a huge carer burden impact for the families involved. And it's really important that we understand this when we're managing MND patients, because for many years we didn't know this was happening. So it's really important, and it's important that we can share with families our understanding and engage with people in a more appropriate way regarding their management. Next slide, please. And I suppose this is really important, that the illness causes the difficulties and the challenging behaviour and not the person. But we know that 50% of our patients are not affected, but 50% are, but that raises huge dilemmas for healthcare professionals and for families. Next slide, please. The impact on healthcare professionals. Of late, we've spent a lot of time in supporting nursing homes, hospices, in dealing with the challenging behaviour. And the cognitive and behavioural deficits are challenging for healthcare professionals, and they're associated with reduced adherence to medical treatments and compliance with multidisciplinary team interventions. We've seen staff and units where there's been a heightened distress by the staff looking after these patients. There's an increase in sick leave, there's requests for transfer, and staff in these areas have reported that they feel that there's insufficient support from their managers and their team leaders. I think what happens in Ireland from the point of view of hospice care, and it's probably the same over the world as well, is that hospice care usually end up with the most challenging and the most difficult patients because their families can't cope. So it has an impact then on the care of the staff. So we have a programme where we try and support the family and the patient, but also the healthcare professionals who are providing care for these patients. Next slide, please. It's extremely challenging for healthcare professionals to engage with and to develop appropriate care plans for patients who have difficulties concentrating, planning, organising, reasoning, and lack insight. Disinhibited patients may have difficulty with impulse control, their risk assessment, the driving. Like, we have great difficulty sometimes that, Professor Hardiman might suggest that it's not a good idea if somebody continues to drive, and the family will say, but you know, Daddy lives in a rural village and he only goes to get the paper and get some milk in the morning, and we don't have a problem with him driving. But actually, if you were to say, would you put your baby in the car with Dad, they might change their mind and say, oh no, we won't do that. So these are the challenges that we're faced that we need to address with people. We see irritability, anger outbursts, and this can be very challenging for people, that they've seen this change in behavior in the person that they love. So it's really important that we can say that this is the illness that's causing this inappropriate behavior. As I said, the sexual and the social inappropriateness. And what we have seen as well, even on our unit in Beaumont Hospital, is that sometimes there's a manipulation and a divisive behavior with the patient, where they might identify one member of staff as, you know, they get everything right and they're really good, but the other person is useless and not very good, and they don't want them. So there's this divisive behavior. So we've done in the past is we've sat with the patient and told them that it's very challenging. We had one lady actually who refused to use any means of communication, and she was ventilated, not in our hospital, in another hospital, and she decided then to use an eye gaze. But her only reason for using the eye gaze was to identify nurses that she didn't want looking after, and to identify the nurses that she did. So we have advised in certain units that especially in an intensive care unit, where you might have one nurse looking after one person each day, that actually there needs to be a division of care, and that perhaps it's divided maybe 3 hours, and split the care. And I think what's really important as well in supporting the healthcare professionals and staff to do this, is that we include the patient and the family and explain that MND can be challenging. This is the reason why that we're doing this, in order to provide support for you, but also to ensure that we can look after the healthcare professionals and enable them to continue to provide the level of care that's required. Next slide, please. The compulsive behaviour may include the repetitive movement, rocking, wailing, throat clearing. I think sometimes the difficulty is the fixation on one symptom. And I don't know if we have any occupational therapists who are listening, and we may well have, but or even public health nurses, where we will see that there'll be a new bed and a mattress ordered, and we might go through 10 mattresses, and the person is saying, no, doesn't suit, doesn't suit, doesn't suit, and end up going back to the very first mattress. And then you get the mattress fixed, and then it could be moving on to something else, and it might be the chair, the positioning of the chair. And having an understanding of this, while always being kind and mindful of what we're doing, but having an understanding as well. Like sometimes it could take 20 minutes and you're fixing a cushion or moving a cup, you put a cup on the table and the person will want it, I don't want it that way, I want it this way. So having an understanding of what's happening for these patients is very important. They suffer from a thing called anagnosia, where there's an inability to recognize the existence of the symptoms that they have, or the disability associated with the illness. And it's really important that we understand that this is happening. Next slide, please. So what can we do from a point of view of the cognitive stuff and the behavioral stuff? We need to identify these, identify early deficits. We need to improve communication, increase the support systems for other healthcare professionals, put in personal boundaries, manage the expectations of the patient and the family. We need to be honest but firm regarding the service that we provide, include the patient and the family, in particular the patient, in all the decisions that we make and why we make the decisions. And that the behavioural changes are challenging and may at times be unacceptable for all endeavouring to provide appropriate care. I think in recent years, this has been the most challenging for us as a team to provide support and look after the patients that we're looking after. Next slide, please. So our management from an overall point of view is symptom management. We still only have one disease modification, which is riluzole. We aim to improve quality of life, and we try to have palliative care involved from a very early stage. Next slide, please. So we improve symptoms, we anticipate the needs of the patients and the carers. Our plan is to avoid crisis. We will see people in the clinic every 4 to 6 weeks, but we had clinic yesterday and we have 2 people returning within 2 weeks because their needs they need to return, so that we can ensure that things are in place for them. Adaptation of their environment to promote activities of daily living. We want to maintain independence, promote autonomy, ensure dignity and enhance quality of life. It is interesting to note that despite the challenges of this illness, that less than 6% of our patients are admitted to hospital. And that's because we manage most of these challenging symptoms at home for the patient. Next slide, please. The dysarthria and the dysphagia, the difficulty with swallowing and speaking. The ability to communicate is a fundamental human activity. The bulbar impairment is one of the most important clinical problems because it impacts on swallowing and communication. The impairment may range from mild dysarthria to complete anorexia. And the cognitive and language impairment, the deficits of verbal fluency and spelling are issues that we have to deal with. We had a gentleman a few years back. He was a taxi man in Ireland, and he had two daughters who were both doctors. They were very accomplished young women, and their dad had a bulbar onset MND, and they didn't realise until he had his diagnosis that actually he didn't know how to read or write. And one of them said, Jesus, Dad, you went every day to get the newspaper in the shop, and what were you doing buying the newspaper? And he said, well, that's what people do. You buy the newspaper, you go down, you have a chat with the locals, and nobody knew that the man had never learned to read or write, but he was very successful, managed, and that was the time before you had sat-nav, so he managed to find his way around Dublin and provided for his family. So it's just some of the interesting things that we come across. Next slide, please. The speech. A lot of our patients would say to us, they'd rather lose their hands or their legs than lose the speech, because it adds to the isolation, the frustration, the increased fear and the anxiety that people have. It's low self-esteem, loss of control, and increased sadness. And I think sometimes if people have difficulty with this speech, there can be a perception that perhaps their intellect is affected and they're not asked, and their opinions are not sought. So we have to be very mindful to ensure that we continue to do that. Next slide, please. As I said, bulbar dysfunction and related communications. Secretion, respiratory complications are issues that we like to address in advance. Up to quite recently, we hadn't been doing voice banking on everybody, and we had a patient who was a very well-known commentator, and his wife was very cross that we hadn't voice banked and message banked his voice, because again, we got around to doing it. He had changes. So we've changed our policy, and everybody is given the opportunity when they come to our clinic from day one, if they want to have the possibility of voice banking or voice messaging. Next slide, please. We use a cough assist. Again, these are set up by our physiotherapist out in the community. It's a non-invasive therapy that safely and consistently removes the secretions of patients with an ineffective ability to cough. So the non-invasive ventilation and the cough assist is a really good way of managing the symptoms from a respiratory difficulty for patients. It removes the secretions from the lungs, reduces the recurrence of respiratory infection. It's safe, non-invasive alternative to just suction. And it's easy for the patients and the caregivers to operate, and most of them will have it at home. We managed to get medical cards in our country for all of our patients based on the fact that it's a terminal illness, and that Orla will say that it has a life expectancy of less than 2 years. And once patients have a medical card, all of this equipment is fully paid for. So that's really important that we have all that sorted for them. Next slide, please. We know that nutritional decline can occur in the context of evolving swallow problems. But as I said before, the weight loss may also be due to the hypermetabolism that occurs with respiratory compromise. So our dietitian and our speech therapist will advise around modification of food and fluid consistency. And we tend to do radiologically inserted gastrostomies as opposed to PEG. Our biggest difficulty in all the services that we provide is timely admission for patients who require RIG. And that's based on bed availability in the hospital. That's the only service that we struggle with, and we have less control over that. Our studies have shown that there can be a wait of 8 to 10 weeks, and for some people that can be too long. So that's the one thing that I feel that we need to really concentrate on and try to improve. Next slide, please. We know that majority of patients are going to die from respiratory failure, and the presence of respiratory muscle weakness is an independent predictor of quality of life. At our clinic, we have somebody who, we have a nurse who measures everybody who attends the clinic. We do forced vital capacity. We do the sniff nasal inspiration pressure, which gives us an indication of the prognosis of the illness, where they're at. We look out for breathlessness, early morning headaches. nocturnal agitation, nightmares, confusion. And we have a policy that if you have a forced vital capacity of less than 50 or a SNP of 40, that we will set you up and give you a trial of NIV. This is all set up at home. It's also an opportunity when we set NIV up at home to discuss patients' end-of-life decisions. We tend not to have patients invasive mechanically ventilated in Ireland, and there isn't the resources to do it, so it tends not to happen. So we actually, our preference is for NIPI, but we do explain to patients, and it's a nice conversation to have. It's much easier to have it in the person's home. We talk about the importance of NIV, the stage that their illness is at. When we set people up on NIV, we make a referral then to palliative care, so we get palliative care services in at that stage if they need cough assist, and we would talk about the impact of having invasive mechanical ventilation. Our purpose is to ensure that the person is fully informed, that they make decisions, and that their GP, primary care team, and all the people that are involved in the care are aware of the decisions. We have a very nice document that's being developed by the Irish Hospice Foundation, and it's an advanced care directive, but it's also a think ahead document, and it's a very useful document to go through. I think sometimes when people are at this stage, like we go in with a plan to have a discussion about end of life, sometimes it doesn't always happen because it depends where the person is from their point of view, but it's very useful and we can revisit. So this is what we do at home with patients. Next slide, please. Our criteria is from symptoms of hypoxemia, FVC less than 50, SNP 40, pulse oximetry. We would only do ABGs if we had somebody in the hospital. There is evidence to show that NIV may, if you can use it for more than 5 hours a night, may increase survival. We advise against oxygen because it decreases the respiratory drive. Although sometimes at end of life we can use oxygen from a comfort point of view. Discussions around invasive ventilation and the possibility of locked-in syndrome if you are ventilated. Next slide, please. For most patients, maintaining control is very important. So it's their place of care, providing family care and support. For some people, it's 24/7. There's a huge financial burden. They need to be fully informed. They need to be aware of locked-in syndrome. And when we have these discussions, for some people, their end-of-life wish is not to die. And for others, there's worse things than death. And the fear of being kept alive on a ventilator is their biggest fear. Sometimes when patients are on NIV, they have said to us that they don't want to be kept alive indefinitely on a machine, and then they get to the stage that they're actually 24 dependent on NIV. We have had, I think, about 5 or 6 people who have decided when they've got to the stage of being on NIV 24/7 that they don't no longer want to have that support. Now, from an Irish legal perspective, they're allowed at any time to stop having NIV, and with the support of palliative care, we have withdrawn, following their consent, we have withdrawn NIV and they have died peacefully at home. So we have managed to do that with NIV. Next slide, please. This is just an interesting paper. It's by David Oliver in the UK. I've often shown this to patients. It's about the medication that's used, because oftentimes patients will say, I'll be okay when I'm dead. My concern is, how am I going to die? So this can be quite useful to show. And really what's important there is that one of the sentences there, that all patients in this study were reported as dying peacefully and without distress, and that patients and families can be reassured that with good symptom management and the best use of medication, that dying from MND can be peaceful. Now that might seem kind of scary, but actually for lots of patients, it can be very reassuring for them to read that paper and see those statistics, and then we can talk about how they may die. Next slide, please. So the end-of-life decisions, as treatments are limited, inevitable decisions regarding accepting or forgoing life-sustaining therapies will have to be made. The failure to discuss advanced care directives can lead to unplanned interventions, particularly mechanical ventilation. An acknowledgement by the patient at some level that death while not imminent, will be the outcome of the disease. So you can't go in and have an end-of-life discussion with somebody if they're not on that page. We use the think ahead document. There's an assisted decision-making capacity amendment, which is being brought into law here. and we use advanced care directives. Next slide, please. Advanced care directives are being recognised here as a very important tool. I did a study a while ago, and that despite the fact of having an advanced care directive, patients were really dependent on the attending physician as to whether their wishes were respected. So that it's really important that we have these discussions, that their families are informed, and that they have that these documents aren't in a drawer somewhere where they can't find them, so that if something happens in a hurry, they can put their hand on it. And that we share this information that we have with other healthcare professionals. And I think as well that healthcare professionals also have a right to their autonomy and the right to care for individuals without abandoning their own integrity. When I did that study before, I interviewed intensive care doctors and intensive care nurses and outpatient nurses. Now, I wear a palliative care hat in caring for MND patients, but their objective was to save life. And they found it very difficult then to go from intervening to save and to do everything to keep alive, to have a palliative care approach and to step back and just to manage from a symptomatic point of view. So we need to include our colleagues as well, because they have a different approach in how they care for patients. And from an Irish perspective, sometimes you're better off if you're not in hospital. You have a better chance of having your wishes respected. Next slide, please. This is just about autonomy. And it's a status, but a skill, but one that must be developed. And the healthcare interactions rely upon assent rather than upon genuinely autonomous consent. And throughout most of their lives, patients are socialized to be heteronomous rather than autonomous. And like this just means, like, you know, if you go into hospital, you'll assent to have a blood test. You'll sign a consent form to go to theatre. And then at the worst possible times, when life and death consequences are attached, we're asking people to make these decisions. And sometimes the answer is, well, nurse, what would you do? What would your decision be? So we have to inform these people so that they can make decisions. And it may be a journey with them, that it's not just a one visit or a one discussion that they make these decisions. Next slide, please. I suppose patients need to be aware that their autonomy is not absolute, that they cannot insist on receiving specific, unrealistic or illegal treatments. Like, we have some patients who actually, their request is that they want to be electively ventilated and kept alive. We can't do that. They want to have certain drugs and we're not in a position to provide that. So that everything that we do is evidence-based. And sometimes that can be in contraindicate for what the patient and the family wanted. We had a gentleman one time, he had a CA of the stomach, and he was considered not suitable to have a rig or a peg insertion, but his sister, who was he should be given the advance of the rig, even if it meant the table, and it was. So next slide, please. So our management is a team approach: early referral, prompt intervention, flexibility, frequent assessment, multidisciplinary team. We don't have a waiting list for our clinic. We're the only clinic in Beaumont that doesn't have a waiting list. Now, the downside of that is we started our clinic yesterday at 11:30 and we left at 9:10 last night. But we do have a walk-in system, and patients are used to that. When they're well and they don't want to come, they'll say, I'm grand, I don't want to be there. But if they have a problem, they can ring us and they will be seen fairly promptly. Next slide, please. As I said, we'll see people depending on where they are. We'll visit them in their place of residence. We maintain close contact with patients, family and healthcare professionals. We do primary care teams, meetings, the hospitals, nursing homes, and now I need to add prisons to that list as well. So next slide, please. So our nursing service, specifically is in-house national integrated service. We take a leading advisory role regarding patient management. We provide advice, support and guidance to all healthcare professionals. We have educational programs established in hospice, nursing homes, other hospitals, in universities, and we'll go wherever a patient is to support staff. We advocate on behalf of the patient to ensure that they receive the appropriate and timely intervention to make good quality of life and ensure their end-of-life wishes are respected. Our policy that we've developed is in keeping with the Sláinte Care, which is a programme that's been funded by the HSE. And actually that's why we've managed to get all our service completely ring-fenced and have that financially supported. And as I said, less than 6% of our patient population have required admission. Next slide, please. That's just a multidisciplinary team. Go next slide, please. This is just showing off. We've showed that if you attend Bowman Hospital on our multidisciplinary team, we can increase your survival by 9 months. That's quite significant given how it is for some people. Next slide, please. So the challenge is that there's a knowledge deficit at community level, delayed diagnosis and variable quality of life. There's an unpredictability for the course of the illness for some people. There's a heavy burden of care. MND patients can be perceived as being very demanding. That's due to the behavioural difficulties that we have. And there's ethical issues regarding end-of-life decisions. Next slide, please. ALS, or MND, has been identified as an illness that is particularly prone to engendering a sense of helplessness and failure, which leads to feelings of frustration and de-skilling that can result in healthcare professionals avoiding patients. And this is why we've developed the programs that we have. I was quite fearful that perhaps palliative care were going to step back and say that we were asking for their input too soon because it wasn't specialist end-of-life care. So we feel that if we can support palliative care and other teams, that they will continue to provide support for these vulnerable people. The care of these people can raise difficult ethical dilemmas, shifting from a paradigm of cure to one of symptom control, and palliation is difficult for some healthcare professionals. Next slide, please. Healthcare professionals need to accept the limitations of the care that can be given and approach patients in a positive but realistic way. We face many complex and ethical dilemmas regarding the management of treatment interventions and caring for these vulnerable patients. And everything that we do is promoted an evidence-based intervention that may conflict with the desire and expectation of the patients and the caregivers, but that's what we have to do. Next slide, please. It's a complex disorder. Disease-modifying therapies are limited. Early intervention can alleviate symptoms. Multidisciplinary care can enhance quality of life and improve survival. Next slide. The treatments that currently be offered for people with MND will at best delay the progression of the disease process. They're never curative, so that the care of these patients is palliative from the time of diagnosis. And in caring for these patients, we should aspire to achieve similar outcomes as reported by Linda Ganzini, that most MND patients anticipate and plan for their deaths and have their wishes respected. Next slide, please. This is just our research team. So our plan is to engage in best practice in MND clinic and develop innovations in clinical management that improve the patient journey, to identify subgroups of MND that help to understand the condition and that are important in clinical trials, to develop novel technologies that can be utilised as markers for disease onset, subtype and progressions. We have programs looking at epidemiology, genetics, neuropsychology, biomarkers, health service, caregiver burden, and these are some of the clinical trials that we have going on at the moment. And I think that's it. Thanks very much. Thank you.
Bernie, thank you so very much. That was incredibly comprehensive, and your explanations were brilliant. We have time for one or two questions if anybody's got any questions. I have a little bit of a question. If you had a magic wand and you could change one thing in the whole of your service, is there anything that you would change? Is there any health professional clinic that you would add in, and why?
That's a very easy question. I would have a designated bed in Beaumont Hospital that's just purely for MND patients. Our patients don't want to be in hospital for a long time. We could rotate it. We could identify the patients that we need. We could have them admitted for rig insertion, have them in, have them out, and we could rotate that bed very quickly. And that's the one falling and failing that we have in our service at the moment, and it's out of our control.
Or is it, Bernie? I'm sure it will be in your control in some way, knowing the powerhouse that you are.
We try very hard. So
that's fantastic. Bernie, there are no questions that I can see, so I can say to the delegates, if you do have any questions afterwards, I'm sure Bernie would be happy to answer those via email if required. So Bernie, a huge thank you from me,